Hello class, I'm going to continue with where we left off in our classroom on Wednesday. We finished with hypothyroidism and then also talked a little bit more in detail about the extreme case of hypothyroidism called myxedema. And we're very concerned when our patients face a potential myxedema crisis where everything is in a very depressed and low metabolic mode. And just remember too with myxedema, this is a very rare disorder. It is the extreme case of hypothyroidism. It's a medical emergency, and the patient will almost be near death. Sometimes they're very unresponsive. There's issues with decreased breathing, low blood pressure, low blood sugar, and low body temperature. So that's why interventions quickly are most important to hopefully save and help the patient recover from this state of a very, very severe state of hypothyroidism. I think it's quite obvious that when we talk about hypothyroidism, as we talked about the other day, that we see probably more cases of the hypothyroidism than we do maybe with hyperthyroidism. But it's just very important to just understand, that the situation can become very severe. It may start as a very mild form of hypothyroidism where the patient is starting to exhibit or experience signs of decreased metabolism. And as we talked about before, there can be many reasons why the thyroid cells fail to produce sufficient levels of thyroid hormones, such as T3 and T4. The cells themselves can be damaged. Thyroid cells may be functional, but not enough of iodide and triacin to make those thyroid hormones. So it could be a case of not having the proper nutrients to produce thyroid hormones. And that's why just a simple TSH level can kind of alert the healthcare provider as to whether or not maybe the patient is suffering from hypothyroidism, because with this decreased metabolism and inhibited secretion of T4 and T3, it causes the hypothalamus and the anterior pituitary to make thyroid stimulating hormone more frequently, and just keeps secreting that to continuously kind of stimulate that thyroid to say, hey, you need to release T4 and T3 for normal metabolic processes and normal metabolic rate. And so that's, what we're looking at when we talk about hypothyroidism. And, it just makes sense that it's important to just understand, what kind of symptoms the patient may start to experience. And sometimes these really go on for quite a while. It can be a slow, insidious onset of this disease. And, until the patient or the person starts to feel really bad, they may say, hey, I've got to go see the doctors because I just feel awful. I'm so fatigued. I'm putting on weight. They may start to notice changes with their GI tract becoming constipated. Maybe younger women may start to develop menstrual disturbances. They might notice a change in their hair. It becomes very thin and coarse. Their nails become very brittle. Their skin becomes very dry. And many times they start to experience a lot of numbness and tingling of the fingers. And as this continues to exacerbate, they might even notice that their cognitive thinking is not as sharp as it used to be. So some of those early symptoms are weight gain, constipation, cold intolerance, fatigue, and weakness. sometimes they might just feel a little more depressed than normal, and might really experience a lot of joint or muscle pain. And as I said, might just really notice a difference in their hair. And maybe their beautician who does their hair may notice that their hair consistency and the texture is very different from what it used to be if a person's been, maybe doing that person's hair for a while. Late symptoms, if these people do not really seek medical attention to make this diagnosis of hypothyroidism, late symptoms could be slow speech, dry flaky skin, thickening of the skin, puffy face, hands and feet, and really starts to take a toll on their taste and smell. Maybe their eyebrows start to thin out, and later on, this just really continues to get worse and worse. Okay, so over time, this can really very much affect the cardiovascular system, where their heart rate may be very slow, blood pressure may be low temperature, and maybe their chest x-ray may even show that they have an enlarged heart because the heart's had to work harder due to the slower metabolism. So this is where it becomes very serious, and this is where we're getting near to that kind of a myxedema type of a patient, and hopefully someone will seek medical attention when these early manifestations really start to get worse and worse and worse for the person. So that's kind of a little bit of a review, and don't forget too that labs will show that T4s are low and their serum TSHs are going to be high, especially in primary hypothyroidism, because obviously it's the thyroid that is suffering from the problem. Remember too, other lab work that just very often correlates with hypothyroidism is that increased cholesterol level, sometimes increased liver enzymes, and many times these people become anemic. Okay, so obviously treatment for this is to replace those deficient thyroid hormones, and they'll start them on a levothyroxine Synthroid, and they'll start them on the lowest dose until that TSH is starting to normalize, and it takes about a good 6 weeks before the person may start to feel any little bit better with the medication. It's not something that's going to get better overnight, and that's why it's really important that you alert the person to signs and symptoms of hyperthyroidism, because that's why we start them on a very low dose. We encourage them to take this on an empty stomach so you have better absorption, preferably in the morning. But it's also important that we teach these patients about a lifelong therapy of levothyroxine. So we want to make sure that we don't have them on too high of a dose, because we call that overshooting, where then they become tachycardic, start to have dyspnea, chest pain, and things like that. If a person has a history of cardiac problems, they will probably cut that drug in half, and that is just kind of a safeguard so that the patient won't develop a type of hyperthyroidism and cause them to start having angina and chest pain. So that's what we're looking for too, and our other outcomes are we want their weight to return to normal, start to lose weight about 2 pounds a week, and also to gradually increase their activity level, because obviously that has been deteriorating over time because of the decreased metabolism that's occurring. So usually it takes about a couple months before the person starts to feel like they want to do things again and have that energy level to be able to do those things. So that's again just a little review on hypothyroidism. So let's proceed now with hyperthyroidism. And don't forget too to review these thyroid cancers, papillary, follicular, and anaplastic. and these three types of thyroiditis, acute, subacute, and chronic. Hashimoto's is probably the most common type, and that is a specific type of hypothyroidism, okay? So let's talk about hyperthyroidism now, okay? Now we're looking at the other extreme, and obviously it's an increase of thyroid secretions. We might call this like a thyroid toxicosis. The normal feedback control over the thyroid hormone secretion starts to fail, and now we have a hyper metabolism occurring with increased sympathetic nervous system activity also beginning to occur within the body, okay? And it really is basically an imbalance of metabolism caused by an overproduction of thyroid hormones. And many of these clinical manifestations of hyperthyroidism are caused by the body's responses to the demands of hypermetabolism. Okay, so obviously high levels of T3, T4, and if you go back to your anatomy and physiology, remember that T3 does control metabolism in the mitochondria. What causes hyperthyroidism? Graves' disease is one of the most specific types of hyperthyroidism. It's about 95% of all the cases of hyperthyroidism. There can also be non-cancerous growth of the thyroid gland or pituitary gland. There can be an inflammation, irritation, swelling of the thyroid due to some kind of viral infection or other cause. Sometimes an ingestion of excessive amounts of thyroid hormones. As I mentioned before, when a patient is diagnosed as hypothyroidism, maybe the dosage of levothyroxine that they're on may be too much, causing them to start experiencing hyperthyroidism. Or maybe they are ingesting an excessive amount of iodine, okay? And remember, goiters can happen within hypo as well as hyperthyroidism, but not all patients with a goiter will have hyperthyroidism, okay? So everything that's occurring, all these manifestations that you see on this PowerPoint slide, basically are just the opposite of what was occurring to these patients when they were hyperthyroid, okay? Again, this increased metabolic rate will have an effect on all the systems. The integumentary system, where the patient will really become very diaphoretic, excessive sweating. They'll develop fine and soft and silky body hair, smooth and warm and moist hair. Within the respiratory and pulmonary system, they become short of breath with or without exertion. Cardiovascular is a very serious situation where the patient may exhibit palpitations, chest pain, could also have increased systolic blood pressure, or even a widened pulse pressure. And remember, from cardiac, our pulse pressure is the difference between systolic and diastolic blood pressure. Heart rate is very high, tachycardic, and with that, more O2 is consumed, so patients are at risk for developing irregular heartbeats or arrhythmias, okay? Musculoskeletal, they become very weak. Neurologically, blurred or double vision, eye fatigue. Sometimes they develop corneal ulcers or infections, increased tears, photophobia. Their eyelids can also retract, and they develop what we call this eyelid lag. And what that is the upper eyelid fails to descend when the patient gazes slowly downward. And then they can also develop this globe lag. And what this is, the upper eyelids pulls back faster than the eyeball when the patient kind of gazes upward. And of course they have hyperactive deep tendon reflexes, tremors, insomnia, and have really no tolerance for heat at all. They might have a low-grade fever, and emotionally They have a decreased attention span, they're restless, irritable, emotional liability, and really almost display somewhat of a manic behavior. In the reproductive system, a woman may develop amenorrhea, where she really is not having monthly menstrual periods anymore, or if she is, it could be a very decreased menstrual flow, and maybe their libido has really heightened and increased. And again, over time, they might develop what we call that exophthalmos, that wide-eyed, startled appearance. But over time, they become very weak and fatigued. Okay. If they do not seek medical attention with this increased metabolism, the person will experience a lot of weight loss. Really always hungry, increased appetite, just feel nervous all the time, restless. Heat intolerance is probably one of the most common hallmark manifestations or sign. And they really have a lot of frequent bowel movements. And with this heightened metabolic rate, they really have a lot of difficulty with sleep. They just can't seem to relax and fall asleep. They're just always, irritable, restless. They might even feel, palpitations. They might just have a lot of nausea and vomiting. They might have itching overall, heartbeat sensations, hand tremors, hair loss, diarrhea, high blood pressure, and as I said, those protruding eyes. Vital signs, temperature, pulse, rate of breathing, and blood pressure are all increased, along with systolic blood pressure, and physical examination may reveal thyroid enlargement or goiter. And because thyroid hormones directly stimulate the heart, they'll have an increase in cardiac output and heart rate, and peripheral blood flow, and even a hyperdynamic circulatory state. Protein synthesis and degradation are increased, so they have developed this negative nitrogen loss. Glucose tolerance is decreased, they're hyperglycemic, fat metabolism is increased, and decreased fat stores. So this person just is in this hyper state, always appearing nervous, emotionally excitable, fatigue and muscle weakness, weight loss, exophthalmos, tachycardia, diaphoretic, warm, flush, soft, moist skin, and fine tremors of hands with increased heart rate. And just remember too, what these thyroid hormones actually do. And they do affect protein, lipid, and carbohydrate metabolism, and so protein buildup and breakdown are all increased. So over time, without any type of pharmacological interventions, the person will become chronically nutritionally deficient, and they just kind of start to waste away. As I said before, there's many causes, and the most common one is Graves' disease. It's more of a toxic diffuse goiter. Usually the patient, like I said before, has thyroid toxicosis. And remember, Graves is more of an autoimmune disorder where antibodies are made and attached to the TSH receptor sites on the thyroid tissue. And when these immunoglobulins bind to thyroid glands, the gland increases in size and overproduces these thyroid hormones. That's why many times with Graves' disease you will see that the patient does develop a goiter. Hyperthyroidism that's caused by multiple thyroid nodules is more what we call a toxic multinodular goiter. This person may have had this goiter for years, and the overproduction of thyroid hormone is a little bit milder than it is in Graves. And with this type of hyperthyroidism, as I said, that it's called toxic multinodular goiter, there is no exophthalmos with this. So the patient does not have those bulging eyes. And again, hyperthyroidism can be caused by excessive use of thyroid replacement hormones, and that is something we really want to be careful of. And so all these signs and symptoms that I've just talked about are also on this PowerPoint slide, and it makes sense that it's just very, very much the opposite of what somebody with hypothyroidism is experiencing, okay? A very serious situation, okay? These patients will have lipid depletion, nutritional deficiency resulting in weight loss, exophthalmos, and of course all with the nervousness and restlessness will have high anxiety. That's why they really have a hard time going to sleep at night. So that kind of accommodates for why they're so fatigued and weak, the following day, because they just can never get any sleep. And this is just a picture of somebody with exophthalmos, and you can see she has those very bulging and staring eyeballs. And sometimes this can get so bad that these patients at times cannot even close their eyes. And these are other things that happen: mood swings, hunger. They have a lot of frequent stools. Increased heart rate may lead to angina, CHF, intolerant to heat, skin warm and moist. Just a little summary of what I was just talking about, okay? And a lot of times these people really, have this incredible diaphoresis, and really cardiac-wise, they just feel like their heart is going to beat out of their chest because they feel this heart, beating so fast all the time, and they have a lot of problems sometimes with palpitations and the experience of chest pains. The incidence of hyperthyroidism, Graves is obviously the most common condition that can occur at any age, usually women between the ages of 20 to 40, and 10 times women more than men. The toxic multinodular goiter occurs after 50, and women are about 4 times more affected than men. And, what will bring that person to the physician is the fact of these very, very uncomfortable situations and the need to get sleep, the weight loss, and all the other symptoms that I've pretty much described, because they can't understand why they're losing all this weight when really their eating habits haven't changed that much. And they start having, numerous amount of bowel movements every day, and that incredible heat intolerance causing them to have that diaphoresis occurring. And of course their energy levels start to change with that insomnia. They become very fatigued and weak. And of course we'll look at that person's medical history and look at any previous thyroid surgery, any radiation, or any kind of drugs that may be causing a patient to become hyperthyroid. That exophthalmos is edema in the extraocular muscles and increased fatty tissues behind the eye, which actually starts to push the eyeballs forward, okay? And many times because of the pressure that's occurring, that pressure can sit on the optic nerve and may really affect vision. And so many times we see swelling and shortening of the muscles that may cause problems with focusing, okay? And over time, with that protrusion really getting more enhanced, these people cannot close their eyes completely. And so what this could possibly do is dry out their corneas, causing them to be more at risk for developing corneal lacerations and infections. They can also have tearing. You might see them have bloodshot eyes, very sensitive to the light, developing photophobia. And as I said, they have that eyelid lag and eyeball lag. So there may be things that we need to do to help them to close their eyes, keeping their head of the bed elevated, maybe taping their eyes shut, to really help them try to get some sleep and to prevent these complications from occurring within the eye. Many times, you know, when it has been finally determined and diagnosed that the patient has hyperthyroidism, if it's being treated, whatever damage is done with the exophthalmos eyes cannot be reversed. Sometimes the protrusion can be so serious that really the person has a very difficult time closing their eyes, that they actually can do surgery and actually cut back those those tissues of the muscle, that fatty tissue that's occurring, and kind of set the eyeballs more in the sockets, so at least the person can be able to close their eyes. So that's also a possibility if the exophthalmos is really very severe. And with goiters, I talked about how serious a goiter can be. They do classify the goiter as one that might have a 0 classification, a 1, or a 2. 0, there's no palpable, visible goiter. A 1 is the mass is not visible when the neck is in a normal position, but it can move up and down when the patient swallows. And class 2 is that the mass is absolutely visible. Okay, you can see the unfortunate effect hyperthyroidism has on the metabolic issue or end of it, but we can see how, again, it affects every system in the body. So this is our concern, especially with the possibility of someone developing what we call a thyroid storm. Okay, and that is what we don't want to happen. Okay. And this would be considered a serious complication where a patient develops, heart failure, maybe can even go into atrial fib, and a thyroid storm or a thyroid crisis is very similar to the parallel problem of myxedema. The exaggerated form of hypothyroidism was myxedema, and the exaggerated form of hyperthyroidism is a thyroid storm. And that's why we have to really assess and be on the alert for any changes in our patient's temperature, because even the slight increase of 1 degree could really alert us that the patient is going to experience a thyroid storm, and again, that is a medical emergency. Sometimes these thyroid storms can occur after a surgical procedure. The complications can be related to the replacement of thyroid hormones. But with a thyroid storm, usually the temperature is extremely high. We're talking about 104, 105, sometimes 107. If that temperature gets that high, we're always concerned that it could possibly burn up the brainstem. Okay, and obviously with a significant increase in temperature, we're going to see that the cardiovascular system will suffer as well, with increased heart rate and increased blood pressure. Okay, so our concern is that we have to get that fever down, because with that high fever, these patients really can become very dehydrated quickly, and we have to control the fever. And it's very important that we would use ice and cooling blankets, but never any aspirin, because aspirin can cause the secretion of a thyroid hormone. So the interventions that we would see with a thyroid storm is obviously to assess their respiratory status and get their cardiovascular system under control, as well as getting that temperature down. Promote hydration, usually with normal saline. They might use glucocorticoids IV, treat CHF and arrhythmias. They might give antithyroid drugs such as iodide or Tapazil, and give them some beta blockers to slow down that heart rate, and watch for any respiratory distress. And of course, we're administering antithyroid drugs to block that synthesis and secretion and effects of the hormone. And as I said, put the patients on a cardiac monitor, and really watch their vital signs, especially their blood pressure and of course their temperature. And really watch for those signs of that widening pulse pressure, the difference between systolic and diastolic. We'll give acetaminophen, no aspirin, no aspirin, no aspirin, and watch for any signs of tetany. These patients can really start to develop problems with their calcium levels. Normal pulse pressure is between 30 and 45, so it should never be below 30. So we want to definitely make sure that we're assessing that, not just systolic and diastolic blood pressure, but just watching that pulse pressure to make sure there's no serious numbers occurring with that. Okay, so that's hyperthyroidism, and I think I've covered everything pretty well when we're talking about signs and symptoms, causes, incidents. And now let's talk a little bit about what kind of medications we're going to give to our patients who are diagnosed with hyperthyroidism. And these are just, as you see from the PowerPoint slide, treatments might be radioactive iodine, but you're going to have to be careful if you have a woman who is pregnant. And of course we need to slow that heart rate down, so that's why we might see the patients on a beta blocker. There is a box in your book in regards to if the patients are given any kind of radioactive iodine, what kind of precautions and what kind of discharge teaching these patients need to have in regards to urinating, what would happen if their urine was, if a woman is incontinent or a man is incontinent, if their urine happens to get on the floor or on the outside of the commode. There's just important things that we need to teach our patients about, okay, if they do have this type of treatment for their hyperthyroidism. But and as I was talking about hyperthyroidism, don't forget what you would see in the labs. That's important to kind of make that final diagnosis. Your serum TSH is usually decreased, and your T3 and your free T4 are usually elevated, okay? And as I said, they can also affect, vitamin B12 test, triglycerides, cholesterol test, anti-thyroid globulin antibodies. So these are things that you definitely want to assess, and I'm sure they're going to be ordered if we suspect that a patient may have a thyroid problem, particularly hyperthyroidism. All right, let's continue with talking about the medications. Obviously, we want to give meds that help reduce the thyroid hormone production. One thing that they do give are PTU and Tapazil, and these drugs block thyroid hormone production by preventing iodide binding in the thyroid gland. PTU specifically prevents T4 from being converted to the more powerful T3 in the tissues, okay? The next one that we use are iodine preparations, may be used for short-term therapy before surgery. These decrease blood flow through the thyroid gland, decreasing the production and the release of thyroid hormones. We usually see improvement, usually occurs within 2 weeks. but it will take a little bit longer, a few more weeks, before metabolism returns to normal. And again, we have to watch for any signs of possible hypothyroidism, okay? Another med they may use too is lithium. Lithium also inhibits thyroid hormone release. But you also want to watch the side effects of lithium. It can cause depression, diabetes insipidus, tremors, and even a lot of GI problems like nausea and vomiting. Of course, we'll give beta blockers to support the cardiac system and reduce that heart rate. Can also help, relieve the diaphoresis, anxiety. They're not going to do anything to inhibit the thyroid hormones, but we're treating these manifestations that these excessive amounts of hormones are causing, okay? Another thing that they may give is radioactive iodine. Obviously not for pregnant people because it can cross the placenta. They can receive this radioactive iodine in the form of an oral medication, and it takes about 6 to 8 weeks for a complete relief of symptoms. The thyroid will take up iodine in any form, and what radioactive iodine does is actually concentrates in the thyroid and damages or destroys thyroid cells, so they produce less of these thyroid hormones. They don't have to be in the hospital when they're given this, but you definitely want to watch for any possible signs and symptoms of hypothyroidism. Sometimes one dose may be enough. Those are some of the medications. Another one that we give is iodine sources like Lugol's solution, SSKI, Thyroblock, potassium iodide. You just want to watch for any allergies that the patient may have. Some of these are given orally, these solutions. Usually you can dilute it with maybe like a cup of juice, and the reason we dilute them is because of a bitter taste, and sometimes they can stain the teeth. Always assess what other medications your patients are on, especially Coumadin, because when they get these iodine sources, it can increase bleeding if a patient is taking these along with Coumadin. Now, you wouldn't want to be on some of these iodine sources for long-term therapy. That will not be effective in controlling hyperthyroidism for a long time, okay? Now, those are some of the most common medications that we use, and sometimes the patient does not respond much from these medications, really showing some improvement in their hyperthyroidism. So the next thing that maybe might have to happen is maybe radiation or surgery. And if that's the case, then these patients will have to take replacement thyroid hormones for the rest of their lives, okay? So I just want to go over a little bit about a thyroidectomy, subtotal as well as a total thyroidectomy, just to kind of talk about what your responsibilities are when the patient comes back. And obviously, as I've stressed in the past before, look where the thyroid gland is. It's very close to the trachea, to the airway, to the carotids, to the esophagus. These patients who have any type of surgery to that area will be in a critical area overnight for observation. Prior to doing a thyroidectomy, pre-op, they will give anti-thyroid meds such as an iodine prep. And this is where we do a lot of teaching, because this is where we want to teach the patients when they're alert and oriented, that we want to show them how they're going to support their neck when they're moving, when they're coughing, post-op. Let them verbalize concerns. You might want to tell them they might have a thin scar that's visible. There may be some swelling, and with that swelling, the patient may experience a little bit of hoarseness with their voices. Okay. Obviously, we want to let them know that they'll be in a critical care area for maybe a day or two, just for observations, to make sure that there's no problems with calcium balances, respiratory distress, infection, or even bleeding. Those are the things that we're going to definitely look at. We want to first pre-op get them in a euthyroid state, and then monitor for hemorrhage, edema, looking at the airway, looking for any signs of laryngeal nerve damage, any hypocalcemia due to the removal of the parathyroid glands, if they did remove the parathyroid glands, and really looking for any signs and symptoms and manifestations of a potential thyroid storm or thyroid crisis. Okay, and I just went over all that. So those are the things that you got to watch. Obviously, comfort measures. Patients may have some pain. The most important thing that you want to have at the bedside, if a patient has a subtotal or even a thyroidectomy, is a trach tray. Because if that patient starts to hemorrhage, the only thing that we're going to be able to do to save them is do an emergency trach on those patients. Okay. We also want to keep them in a semi-Fowler's position to kind of reduce the stress on the suture laying. Usually if they're going to bleed, they're going to bleed in the first 24 hours. So that's our main concern in those first 24 hours, is to really check for hemorrhage. And of course, respiratory distress. Might want to provide a little humidification in the room. And of course, due to the fact that those parathyroid glands may have been tampered with. Now, many times if they're going to do a total thyroidectomy on these patients, they can implant those parathyroid glands somewhere else on the body. But we watch for signs of tetany, laryngeal spasms, any kind of damage to the laryngeal nerve. If your patients develop any kind of stridor, and we know what stridor sounds like, that is a sign of respiratory distress. And you want to get that trach tray ready, because you want to call that doctor immediately, because there's a lot of swelling and a lot of serious potential for the patient having severe respiratory distress. So those are things that you really, really want to watch for when these patients come back from surgery and they're in the intensive care. Tetany is a sign that they have a low calcium level, and they might have a positive Schaff-Sticks or Trousseau sign. And I'm going to let you recall what is the check for a positive Schaff-Sticks and a positive Trousseau's. When your patients also come back from any kind of thyroid surgery, you want to keep calcium gluconate and calcium chloride IV on hand, just in case they do develop tetany, and you'll be able to give them a quick IV dose of some calcium to hopefully reverse those problems with those positive signs of Schaff-Sticks and Trousseau signs. Okay, so please think about what those are. You might see those on the test, and I'm not going to tell you what those are, because that is basic A&P when you talk about abnormal calcium levels. Okay, so just a little bit of a reminder about that. Okay. So obviously, with a thyroidectomy, it may be done for many, many reasons. Sometimes the patient has been diagnosed with a malignant tumor or even a non-cancerous tumor. Okay, can be done to treat the thyroid toxicosis. maybe to remove all or part of a goiter that is pressing on some of those adjacent structures, especially if the goiter is interfering with a patient's ability to swallow or to breathe properly, or also to remove and evaluate an undiagnosed thyroid mass. As I said before, pre-op, they're going to get that patient in that euthyroid state, okay? And they're going to tell them about, post-op, especially if it's a total thyroidectomy, how that person will have to take anti-thyroid drugs as prescribed, okay? Might want to keep suction equipment. They're going to be on some maybe O2. Limit the patient's talking. That's why if you communicate, just make it simple and ask yes or no questions. And as I said, bleeding, open airway, encouraging the patient to whisper, a trach tray at the bedside, okay? Just do all those things that we do for someone who comes out of surgery, airway, listening to breath sounds, checking pulse ox, and really telling the patient not to really speak, okay? So that's pretty much what we, do for a patient who is having a subtotal or a total thyroidectomy. And again, this is just, a reminder about the possibility that maybe the surgery was a trigger to set off a thyroid storm. And again, these are what you would see the patient manifest, okay? And we've already talked about hypothyroidism and levothyroxine, Synthroid and Levothyroid. And again, needs to be on medications for the rest of their life, okay? So I hope that makes it clear how important the thyroid gland is, okay? We talked about, how, the thyroid is responsible for metabolism. And, that's very true. But the T3 and T4 are also, again, to remind you that it is responsible not only for metabolism, but also for fetal development, neural and skeletal systems, the metabolic rate of cells, promotes sufficient pituitary secretion of growth hormone and gonadotropins, regulates protein, carbohydrates, and fats, increases red blood cell production, affects respiratory rate, increased bone formation, and decreases bone resorption of calcium, and also acts as an insulin antagonist. So that's why we saw these patients who were hyperthyroid develop some issues with their blood sugars, okay? So just a little reminder, and please go over these things so that you really understand why each of these manifestations are definitely occurring with your patient, okay? I'm going to conclude here, and then I will begin another a lecture on parathyroid. Thank you.